how much work is happening, but also how much work we need to be doing across so many areas of the sector. Leadership, data, culture, just it's a big challenge. And I'd also encourage people to go to that website. I had a look at it myself in preparing for today, and there's a huge amount of information there about what is happening. Now, Jeffrey, we have one more person to go, and then we're going to go to a panel discussion. Our next person is from Western Australia, Dr. Audrey Koay, who's also going to be talking from a systems approach. Audrey is Executive Director of Patient Safety and Clinical Quality at the Western Australian Department of Health. And she's going to be presenting on system approaches to value-based care. Audrey.
Thank you very much, and good afternoon. So very much like George, I'm just going to share the WA approach to doing this as a state. Now, brilliant. So I thought I'd just give you a little bit of a history. So whilst value-based healthcare has been going on for quite a while, it's mainly happened in pockets. So in 2017, we formally launched a statewide approach to value-based healthcare, and we call it the High Value Healthcare Collaborative. And it may be of interest to know that this work actually started from the health technology assessment units, which mainly looked at the introduction of high-cost drugs and high-cost procedures and technologies. And this was one of their pieces of work. So initially, the High Value Healthcare Collaborative focused on three main areas. So end-of-life care and reducing inappropriate interventions there, sepsis management, and also propagating choosing wisely initiatives across all of the health services in WA. And the idea really was to build a community of practice and facilitate models for engagement. And in particular, we weren't interested just in hospitals talking to other hospitals. We really wanted to bring primary care consumers and other agencies such as paramedics into this conversation. So the collaborative was focused very much on both knowledge transfer, particularly of what's worked and what hasn't worked, and also on mapping and producing data to support this work. So coupled with that, the work of the collaborative, we also did some work around rationalizing or looking at how we introduce high-cost drugs. So this was kicked off with the Formulary 1 system, which is essentially a statewide medicines formulary. And it's got two main ambitions. One is equity of access. So no matter which hospital you go to, you get the same level of care. And the other is to introduce value. So looking at safety, but also looking at the cost effectiveness of some of the drugs that were introduced. So we were pretty chuffed when in 2019, the government released a Sustainable Health Review report, and the work of the High Value Healthcare and the Formulary team was recognized in one of those recommendations. I'm just waiting for the screen to change. So the Sustainable Health Review echoed very much some of what George has spoken about concerns around the rising cost and consumer expectations in healthcare. So the Sustainable Health Review was a multi-agency, cross-government approach to managing the growing cost of health. And it focused not just on the acute hospital sector, but also what needed to be done in the prevention space. And it was very, very strong on having a better consumer voice and multi-agency approach. So of the 30 recommendations, recommendation 16 relates to high-value healthcare, and it's very much focused on reducing variation and ensuring only treatments with a strong evidence base are funded. And I was quite interested by what Tony was talking about, because in the initial stages, it's focused on public reporting, but in its more mature phase, we actually want to look at commissioning. So in 2020, we had COVID, though our version of COVID was very different to many other places of the world. And we moved a lot of the focus to opioid stewardship and antimicrobial stewardship. But one of the interesting things that happened in COVID was we had the opportunity to have discussions about doing things differently. And there were things that were stopped that perhaps didn't need to resume. So our current focus is on low value care. We're running some kitchen table consultations, which are just a bit more intimate conversations with consumers to better understand their perspective of value, but also around how we empower consumers to have conversations with clinicians and surgeons around some of the procedures that are options and whether they shouldn't be options. We are also focusing on the use of data and capability building. And the capability building is on two fronts. One is around the use of data and data literacy, and the other is around the culture and the skill set that's required to deliver this. So I was now going to just talk a little bit about our reflections on where we are today. So if I look back at the approach we've taken, it's sort of been a mixture of didactic approaches, having some forcing functions like the formulary system, things that you can't do, and establishing a community of practice and then crossing our fingers and hoping that things come together organically. Where I want to go next is a conversation about how we're reframing the conversation with consumers and with clinicians. So we can go to the culture slide now. So key to this conversation is addressing some of the cultural barriers. And the three main conversations or friction points that we're constantly running against. One is the perception by consumers when we talk about low value care, that we're essentially rationalizing access to treatments as opposed to reducing inappropriate treatment. The other is with clinicians and the perception that we may be robbing them of their autonomy. And the third one is around data and the fact that we have, I think many healthcare systems are very protective of data and we don't use it for improvement. So the other environmental context which is relevant are the clinical care standards which have been published by bodies such as the Commission of Safety and Quality. And they particularly like these because they're actually part of the national standards accreditation. So compliance is actually required in order to get accredited. Some of them are more or less useful than others, but what they do set the scene for is a conversation around reducing variation and also around particularly things like the colonoscopy standards where care may be inappropriate. Sorry, there's a lag. The other part of our reframing conversation is around professional accountability. So I think we've moved from a conversation where people are told how to practice medicine to we're now giving you the tools and creating the environment of professional accountability. So we bring groups of clinicians who manage similar patients in similar settings together. They can talk about best practice. They've got access to the literature. They've got access to opinions. And importantly, we also give them access to contemporary and credible data that shows their performance and their outcomes. And typically we bring these together in one of two forums. One might be in statewide audits of outcomes, and the other might be in looking at quality improvement collaboratives. And this is a conversation that I actually have to thank the colleges for, because they've actually been very useful partners in having this conversation. And finally, we're also building into this a paradigm shift. So rather than tackling this from a performance perspective, we're having a conversation about improving the quality of care for everyone. The other reason why I put this slide up is because we want to incorporate more of the quality improvement science and quality improvement methodologies to the change management and the behaviors that are required in order to facilitate more uptake of value-based healthcare. So as I've mentioned, data is a strong linchpin in our work. And so much of the focus in recent years has been around liberating some of that data back to clinicians. So all the dashboards that we create are basically accessible to anyone who works in the WA health system. All you need is an HE number to basically access them. And we've created dashboards that compare hospitals, for example, in a funnel plot, or which compare a hospital against itself over time in SBC charts. And we've done this for cancer, obstetrics, cardiology, mental health, and a couple of other smaller groups. And we've got two different sorts of dashboards. I think of the one that you're looking at as the dashboards that management and executive look at. It tells them where their hospital is, but it doesn't necessarily tell you why their hospital is where it is. And I think that second question is the more interesting one, if I can just move my slide on. There you go. So underneath those executive or management dashboards, we've got dashboards that we've created with clinicians using our linked data systems. And it's basically an exercise where we sit down with craft groups and ask them what question they would like answered in order to understand why patients have received a particular care or particular treatment and what information they would need in order to change or to identify unwarranted variation. So we've got different things that this is an ED dashboard that shows you when patients come in based on the time of day. We've looked at things that might guide decision making, where patients come in, where they go out, and things like that. So in summary, I think we've moved from something which is a little bit fingers crossed and ad hoc, hope it works, to trying to create a more structured approach. The other key difference is that we're trying to bring the consumer voice in much more strongly, and we're having different workshops with them where they actually define what good care means from their perspective. A lot of the work is around capability building, and part of that is about giving data back and enhancing data literacy. But the other component is around enhancing QI capability, but also giving people tools that take into account human factors and trying to nudge people into different directions or different decisions. And finally, I think the key component here is recognizing that in the acute hospital setting, you're basically reacting to what's come in the door. So having the conversation just in hospital isn't going to cut it. We also have to have that conversation with community providers. And particularly in relation to low value care, we have to have that conversation with the private sector. It wouldn't be fun if I didn't. So. And lastly, just in case anyone thought that I did any of that work, this slide is just to acknowledge the team who did the hands-on work, in particular the Medicines and Technology Unit, the Healthcare Quality Intelligence Unit, and the Mental Health team. Thank you.
I think it went well beyond fingers crossed and ad hoc. I think what you've done over there is very is quite fantastic, and it's great to be able to share it with the rest of the country. And one day we'll all be able to get over there and visit. But now I'm going to hand over to Jeffrey. We've got a panel discussion.